And we are so lucky to have Professor Frank Hugh from Harvard here to continue. I mean, for this group, everybody know carbohydrate qualities. And Frank really doesn't need any introductions for folks in nutrition and epidemiology. And he's been leading the charge for close to 3 decades now. I can use up the entire 25 minutes of his presentation to introduce him because I've known him, the two of us started out in the same institution, in the same room, literally almost 3 decades ago. But just very quickly, Frank is the current Stair Professor of Nutrition, Epidemiology, and Medicine, and also chair of the Department of Nutrition at Harvard Chan School of Public Health. And also a member of the National Academy of Medicines. He has received many, many awards in the field of, in the domains of epidemiology, medicines, diabetes research, cardiovascular disease research, and I can go on. Like I said, that without further ado, when I see the room is start filling up, Frank, is all yours.
Good afternoon. I hope everyone had a very good lunch and not sleeping right now. And I want to thank Simin for your kind introduction. I must admit that Simin is much more adventurous than me because 30 years ago, once I got settled in Boston, I have never left. But Simin has been going back and forth between West Coast and East Coast. And also, I want to thank Simin for his pioneering and foundational work in the area of carbohydrate quality 20, 30 years ago. And his seminal work has really laid the groundwork for many subsequent studies conducted in our cohorts and many other studies, and also has laid the foundation for many of the public health recommendations on carbohydrates, including the dietary guidelines. So today I'm going to give a quick update on our recent work on carbohydrate quality metrics and the risk of type 2 diabetes. Most of this work was actually conducted by my former PhD student, Hana Alisa, and she is currently assistant professor at National University of Kuwait. And in the last year or so, she has been visiting scientist in our department working on several analyses that I'm going to present today. So as you all know, there has been tremendous interest in the area of carbohydrate quality versus quantity. There are many different metrics for carbohydrate quality, including glycemic index, glycemic load, degree of processing, ultra-processed carbohydrates, liquid versus solid sugars, and so on and so forth. But none of those metrics capture the very complicated dimensions of carbohydrate quality. So that's why we need more comprehensive, more systematic analysis of different carbohydrate quality metrics and approach this issue from multiple angles. So today I'm going to present recent analysis on 3 different topics. The first one is to develop a more comprehensive carbohydrate quality metric and look at this, compare this metric with the traditional carbohydrate quality index in relation to type 2 diabetes. And then the second study is focused on food forms and the sources of fructose and the risk of type 2 diabetes. And then the third study is focused on carbohydrate-based ultra-processed foods or UPFs and the risk of diabetes. The first 2 studies are not published yet, and the third study was just published recently. in diabetes care. It's not moving. Okay. So all the three analyses were conducted using data from our three large cohort studies, the Nurses Health Study, Health Professional Follow-up Study, and Nurses Health Study 2. Those cohorts have been followed for several decades, 4 to 5 decades. And we were very fortunate because over the past several decades, the cohort infrastructure has been continuously funded by NIH. Unfortunately, as many of you know, all the NIH grants to Harvard have been terminated, including the infrastructure grants for our cohorts. So that's really put, this very precious resources in jeopardy. And that's something we certainly want to preserve, and because this resources, including both enormous amount of data and the biorepository, have made enormous contributions to nutritional sciences, and pretty sure those resources will continue to make contributions to both science and policy. So for this analysis, we have about 200,000 participants who have been followed for 3 to 4 decades. And during the follow-up, we documented more than 20,000 incident cases of type 2 diabetes. And the lifestyle and the medical data were collected through biannual questionnaire. And the dietary data were collected through validated FFQs every 4 years. So for this analysis, we have up to 10 repeated measures of diet over 3 to 4 decades follow-up. And the primary analysis were based on cumulative average diet, because the cumulative average, not just to reduce the noises surrounding self-reported dietary measurement, but also represent long-term dietary habits. We also conduct a secondary analysis using only baseline measurement, simply updated diet, and we also conduct a 4 to 8 year likely analysis to reduce, minimize reverse causation and reduce confounding. And we also have large amount of biomarker data. For this study, we analyzed cardiometabolic biomarkers. Currently, we are also planning to analyze the carbohydrate quality indices and metabolomics data and the microbiome data. So for the first study, we analyzed 23 carbohydrate quality variables. So we have individual variables like total carbohydrate, starch, different type of fiber, and then we also have composite carbohydrate quality metrics, including carbohydrate to total fiber ratio, carbohydrate to cereal fiber ratio, and we calculated total glucose equivalence, or TGE, which was calculated by summing the glucose monosaccharides and the glucose from sucrose, high fructose corn syrups, mannitose, lactose, and starch. And the total fructose equivalence was calculated by summing fructose monosaccharides and also fructose from sucrose or high fructose corn syrups. And then we calculated the existing carbohydrate quality index. Stephanie presented this index in the morning. So it's basically a composite measure of 4 carbohydrate variables: dietary fiber, glycemic index, whole grain to total grain ratio, solid to total carbohydrate ratio. We adjusted for traditional type 2 diabetes risk factors, including BMI. In terms of dietary covariance, we adjusted for red meat, different type of fats, coffee. The cereal fiber models were adjusted for fruit and vegetable fiber, whole grain and refined grain models were mutually adjusted for each other. So those are the main results. As you can see that the direction of those associations are consistent with the prior literature and also our expectations. I'm not going to go through all the estimates one by one, but just want to highlight the 5 strongest associations. So we have cereal fiber strongly associated with lower risk of diabetes, whole fruits associated with lower risk of diabetes, glycemic index associated with increased diabetes risk, SSB is also associated with increased risk, and the whole grains is associated with lower risk of diabetes. So those are the 5 top individual carbohydrate variables were strongly associated with either increased or decreased risk of diabetes. And some composite measures like starch to cereal fiber ratio or starch to total fiber ratio were also strongly associated with diabetes risk. However, because the ratio is much more difficult to interpret, so we didn't include the ratios in the calculation of the carbohydrate quality index. So using the 5 top individual carbohydrate variables, we calculated alternative carbohydrate quality index. So this index is more strongly associated with type 2 diabetes risk than the existing carbohydrate quality index. So for the new index, it's about 30% lower risk of diabetes, comparing the highest with the lowest quintile after adjusting for BMI and other covariants. For the existing carbohydrate quality index, the risk reduction was 18%. And then in our secondary analysis, using 4-year lag or 8-year lag, the results are very consistent, very robust. You can see clear separations of the confidence intervals between the existing carbohydrate quality index and the new carbohydrate quality index in terms of their inverse association with diabetes risk. And we analyzed 14 traditional cardiometabolic biomarkers. And in general, the new carbohydrate quality index was significantly associated with more biomarkers than the original or existing carbohydrate quality index. And in general, the associations with the new carbohydrate quality index were stronger than the existing one. So here the biomarkers include blood lipids, adipokines, like leptin, adiponectin, inflammatory biomarkers, and HbA1c and the C-peptide. So this is a quick comparison of the 2 carbohydrate quality index. So for the existing index, as I mentioned earlier, it has 4 carbohydrate variables: total fiber, whole grains, glycemic index, whole grains, total to total grain ratio, solid to total carbohydrate ratio. The new index also include glycemic index, but also whole fruits, whole grains, cereal fiber, and SSBs. So the new index, as I mentioned earlier, is more strongly associated with diabetes biomarkers and also diabetes risk. It's certainly much more comprehensive and better reflect overall eating patterns. To calculate both indices, you do need a detailed FFQ and food composition database for total fiber or cereal fiber and also glycemic index. So the question is, can we use this new index to develop a quick carbohydrate quality screening tool that can be used in clinical settings? So for the new index, we have whole grains, we have whole fruits, and we have SSBs, which can be easily assessed in the screener questionnaire. But for glycemic index, of course, we cannot just ask people about their dietary glycemic index. However, we can ask them about consumption of refined starches, especially white bread, white rice, and white potatoes. And then for cereal fiber, of course, whole grains is an important source of cereal fiber, but breakfast cereals is also important source of cereal fiber. So instead of asking people to fill out 140 item FFQ, maybe we can just ask them to respond to the 5 food-based screener questionnaire, and this takes only 1 or 2 minutes. Of course, this need to be validated against biomarkers, disease risk, and also a full FFQ. But I think if we can implement this kind of screening tool in clinical practice, that can, of course, save a lot of time for the clinicians and also for the patients. For the second analysis, we specifically focus on fructose in terms of its food sources and forms. And here we have multiple fructose exposure variables, total fructose, different food sources of fructose, liquid versus solid fructose, and then fructose from SSBs, from fruit juices, whole fruits, and non-fruit solid fructose. And in this analysis, we adjusted for alternative healthy eating index, which is a marker of overall diet quality, and we also adjusted for subtypes of fructose. So this is mutually adjusted for each other. And in our cohorts, about 30% of fructose come from sugar-sweetened beverages or fruit juices. So those are the liquid form of fructose. And about 30% come from whole fruits. And the rest of the fructose, about 50 to 60%, come from non-fruit solid foods. So, so it means that liquid sources and whole fruits are important sources of fructose in our diet. And then those are the main results. So total fructose is not materially associated with diabetes risk. It's only 4% increased risk. And then liquid fructose, on the other hand, is strongly associated with increased risk of diabetes. On the other hand, solid fructose is associated with lower risk of diabetes. And then when we look at different food sources, so you can see that SSB fructose has the strongest association with diabetes. And then fruit juice fructose is also positively associated with diabetes risk. Not surprisingly, fructose from whole fruits is associated with lower risk of diabetes, but surprisingly, fructose from non-fruit solid food is also associated with lower risk of diabetes. So clearly, there is a distinction in terms of metabolic effects between liquid fructose and solid fructose. So liquid fructose, of course, is rapidly absorbed, and which can lead to liver overload that can promote de novo lipogenesis, hepatic insulin resistance, and also because it's in liquid form, so there is low satiety, which can lead to excessive caloric intake. I also want to point out that the metabolic effects of liquid fructose may not be unique. So it's possible that it's just the liquid form of any sugars, regardless of the type, are metabolically harmful. But fructose, especially in large liquid doses, may be particularly detrimental due to rapid hepatic uptake, promotion of de novo lipogenesis, ectopic fat accumulation, and increased hepatic insulin resistance and inflammation. Another unique feature of fructose metabolism is that it's converted to uric acid, which lead to increased risk of hyperuricemia and also increased risk of gout. And the third study is focused on carbohydrate-based UPFs and the risk of type 2 diabetes. I think you're all familiar with the LOVA classification. So we have group 1, end-processed or medium-processed foods, group 2, processed culinary ingredients, and group 3, processed foods, and then group 4, UPFs. And in our cohorts, we divide the UPF foods into 10 different categories. Most of them are actually carbohydrate-based UPF. So we have bread, breakfast cereals, refined whole grain bread, refined bread. We have sweet snacks, desserts, savory snacks, and sugary beverages. So those are all carbohydrate-based UPFs. And also, of course, we have processed meats, yogurt, and ready-to-eat meals. Hard liquors are also classified as UPF. And then in our analysis, we specifically look at carbohydrate-based UPF subgroups and the risk of type 2 diabetes. So overall, UPF as exposure variable is associated with increased risk of diabetes when we lump all the UPFs together. And then when we look at UPF subgroups, the association with type 2 diabetes is quite heterogeneous. So here you can see that some of the UPF carbohydrates, including cold breakfast cereals, whole wheat bread, is actually associated with lower risk of diabetes, especially cold breakfast cereals. And then on the other hand, we have packaged sweet snacks, and some of them are associated with increased risk of diabetes, some of them associated with lower risk of diabetes. And clearly, sugar-sweetened beverages is strongly associated with increased risk of diabetes. And the results are very similar for CVD and CHD or stroke. And you can say that the worst type of UPFs are the SSBs and the processed meats. So they're strongly associated with increased risk of CVD, CHD, and stroke. And then for the carbohydrate-based UPFs, again, cold breakfast cereals, whole wheat bread is actually associated with lower risk of diabetes. Yogurt and dairy-based desserts were actually associated with lower risk of CVD. So clearly, there is enormous heterogeneity across carbohydrate-based UPFs and also across overall categories of UPFs. So I think clearly the LOVA classification oversimplified the definition of UPFs, and because it's primarily based on processing. And I think there is a need to subclassify group 4 by nutrient quality, not just processing. And in terms of dietary guidelines, of course, we need to target harmful UPFs first, not all UPFs. And for industry, there is many opportunities to reformulate UPFs to increase nutrient quality and reduce harmful nutrients and additives. For consumers, of course, we need to read the labels more carefully. So this is the proposed LOVA class 4 subclassification. So instead of overall just one category, you can divide this into 4A and 4B. So we can have functionally processed but nutritionally beneficial UPFs such as whole wheat bread, fortified high fiber cereals, yogurt with added probiotics and some sugar, plant-based milk or plant-based meat alternatives with minimal additives. So this is more beneficial or neutral UPF category. And then 4B would be highly processed and nutritionally poor UPFs such as SSBs, chips and snacks with refined starches, with a lot of added sugar, sodium, and preservatives. So this category would be more harmful, would be a target for nutrition interventions and policies. So finally, I just want to give a few future nutrition directions. As I mentioned earlier, we need to develop and validate a quick carbohydrate quality screening tool for clinical use. This can be validated against biomarkers and food dietary assessment, and this can be tested using digital platforms in clinical settings. Second, we need to conduct mechanistic studies comparing metabolic effects in liquid versus solid sugars. And then third is to refine the UPF classification using nutrient profiling. Instead of have just a group 4, we can have a group 4A and versus 4B. Of course, this need to be tested for the validity in terms of biomarkers and the clinical outcomes. And finally, we need to design real-world interventions to improve carbohydrate quality and test clinical outcomes. Again, you can conduct pilot digital or food-based interventions and measure changes in clinical outcomes and level biomarkers. So again, I want to thank Hannah Alisa for doing most of the work, and she has been also working with Vasanti on some of the carbohydrate projects, and then Kenny Mozoda, who is a postdoc in our group, conducted the analysis on UPFs. So thank you very much for your attention.
Fantastic. Thank you very much, Professor Hu. We've